Amazon Regional Health Authority.
Through you, Madam Chair, thanks for the question, Member Bodo. Similar to North Central, the experience of Southwest was that from March, the onset of the COVID cases and the system response, we were able to go in initial emergency mode, cooperating with the Ministry of Health and other regional health authorities. So we were able to internally redeploy staff to the emergency departments as the front line in order to manage cases. And as the parallel system started to emerge through Ministry of Health policy, we too depended, like the other RHs initially, on the North Central Regional Health Authority through CUVA and CORA in the first instance. And as the facilities matured, Augustus Long came on stream around July, August. We were able to, with the support of the ministry, go from internal redeployment, even at the request of North Central at the time, being able to assist doing our part with the other RHs to support North Central initially, to then be in a position to hire as our parallel healthcare system matured. So we were able to keep pace with the emergence of the parallel healthcare system that now is relatively mature at this point in time. So we have been able to look at our internal resources to effect the additional hires that were eventually needed.
Yes, Dr. Bodo.
Yes, thank you, CEOs. Again, through your PS to the CEOs, in view of those responses, and for the information of the public, and in view of the fact that our COVID-19 cases and so on seem to be slowing down a bit, what is the status of the regular normal services in terms of clinics and surgeries at the various RHAs, in particular the NCRHA and the SWRHA, and perhaps the others as well? I'm sure that the public would want to know.
Well, through you, Madam Chair, we still maintain some of the constraints based on the pandemic, which determine how many persons can occupy a space at any given time. That's critical so that we mitigate against the possibility of the spread of COVID-19, which arguably is still around if we look at what is happening throughout the world. The issue, though, is that even in those circumstances, we would have engaged telemarketing. To date, we would have engaged at least 28,000, particularly from calls from our medical clinics. We've put our primary care to assist in this regard simultaneously, particularly to distribute pharmaceuticals. So arguably one of the things that we're doing is ensuring that when we do our telemedicine and we do the consultations with patients, based on the need for pharmaceuticals, we distribute the pharmaceuticals close to those to the health centers closest to them for them to pick up. We've noticed as well that there's an increased compliance based on the telemedicine services in persons taking their pharmaceuticals. The implications of that is that we've also now overlapped what we call our telepharmacy services to reinforce the patients that they need to take their medicine. The net effect are better outcomes for patients. So on the one hand, we've engaged telemedicine services for those services, those patients that we could engage. Initially, when we started that service, some of the patients would have interpreted those calls as cancellation conciliatory calls. But what we did was we streamlined our script to ensure that they knew that they were speaking to a doctor and that doctor was in fact providing healthcare on the phones. And we've noticed, in addition to that, increased commendation, but we've overlapped that now with the pre-registration of our first visits simultaneously to ensure greater efficiencies. But those were for those medicine patients. We met during the COVID-19, even at the early stages, we were committed as an RHA and certainly after discussion with the minister to continue to provide our surgical services, particularly Of course, we continue the emergency services, but they were urgent and surgeries that we felt that should take place, and we continue with at least 6,000 surgeries. With those surgeries would have come a corresponding need to ensure that we had clinics running simultaneously, so we would have put tents and so on to facilitate those that were improving as we went. The issue though is that even within the tents and within the building, we still had to adhere to some of the constraints that were put in place based on the COVID regulations. And that would have told us, based on when we did the numbers, how many persons could be inside. And so we basically had to mitigate against any activity and ensure that we didn't engage in any activity that breached the regulations and therefore restricted the numbers. But for the most part, we continued. As I said, we did over 6,000, around 6,400 surgeries during that period, which we really take the opportunity to commend the staff, surgeons, anesthetists, patient escorts, etc., for the dedication during that period. And we try on with continuous improvement. As I said, we engage in structural and continuous improvement, and we're utilizing that systems framework to do so.
If I may continue, Madam Chair, just one more item I'd like to address or have addressed with regards to the key limitations and constraints, and that speaks to the time lag in the approval and implementation process for the design and approval of projects and work activities. And I want to relate this, and perhaps I could address this, maybe PS could address this. I want to relate this back to page 8 of your report, which speaks to the infrastructure and medical devices pillar. And I'm speaking specifically here, PS, to item 6, Roman numerals. In fiscal 2021, the ministry will seek to commence construction works for the establishment of a cardiac catheterization lab at the San Fernando General Hospital. The project is at an advanced stage where the tendering has been completed and is being evaluated. And I just asked to tie that in terms of the time lag in the approval and implementation, because I know that this is a project that has been in the pipeline since about 2014. So I don't know if I can ask the PS or perhaps the CEO of the SWRHA to shed some light on this challenge with this particular example.
Sure. Through you, Chair. Thank you, Member. So just very quickly with regard to this particular project, the evaluation has been completed, and we're currently looking at possible financing options, Member, in terms of going further with the project. All right, we're considering alternative financing models before we proceed further with that particular project. But it is a priority for us and for the Southwest Regional Health Authority. We really want to get that project started this fiscal year. So that is still the intention. All right.
Thank you, Madam Chair. I will leave it there for now.
Can I just inject, Madam Chair?
Yeah, yes, please, CEO.
Yeah, I just wanted to point out perhaps a little further on the question earlier asked by Dr. Bodo with respect to services, given the parallel system and the COVID system. The fact is that we have had to be very vigilant. We face challenges, but we've had to be very vigilant to prevent the overspill from one stream into the other. All right? But I want to point out that we have not been overwhelmed in the authority, and in particular, I can speak for the ERHA, because although we face these constraints, we have continued to develop our services. So, for example, we have opened a new dialysis center in Rio Claro, so that we've not been overwhelmed and curtailed fully by COVID. COVID is there, and we are coping and dealing with COVID through the efforts of our staff and the rallying and so on of the country. But at the same time, with the challenges, the service continues. We've decentralized other services into primary care, ultrasonography, ophthalmology, and others. So that while we are facing those challenges, the fact is the normal system has continued to develop and to move forward. Just wanted to add that. Thank you.
Thank you very much, CEO. Might I now invite Member Bacchus?
Yeah, thank you, Chair, and welcome again to all members and participants. And I too would like to join in what I am sure would be a continuous chorus of praise for all healthcare professionals who are working to keep all of us safe during this time. Woman job you're doing, and I want to add my congratulations and compliments for a job well done, and keep up the good work. I want to go back, Chair, through you just to deal with the initial thing you were looking at, and I did the math, and I know you were talking about the weighting as it related to these implementation rates, and I am truly concerned about it, because basically what happened, as explained, is that all of the individual pillar implementation rates were added together and divided by the number, and you got that 87% number. The danger in that is that it can create somewhat of a false narrative. And I say that from the point of view that some pillars only had 2 activities. Some pillars had as many as 130. And in looking at the implementation percentage numbers, you would see that the one that had 130 had one of the lowest rates at 63. But because the others were so high, 80, 90%, you would have found that the overall rate seemed to be higher than it is. I think you need to find a different way that more depicts in a fairly accurate way what is happening at the individual levels. I also was interested to try to figure out what Chair, you cleared it up, what implementation rate actually meant. And these numbers were for the previous period of 12 activities were completed and now 25 were completed. It is really to figure out whether cumulatively now that number is 37, or is it that it is 25 that then included the other 12. So it is really to get clarity in terms of definition or a taxonomy of how you define the language that you're using, as well as probably a clearer way to depict the numbers so that there is not this nebulousness about what we're dealing with. I wanted to touch on one area of the report at 7. I think it's classified as G. Yeah, the Ministry of Health Administration pillar with the 130 sub-activities is G, and it's on page 11. And I know there is the relationship that exists between the Ministry of Health and all of the RHAs, but I was looking at and very interested in Roman numeral 1 and 2. 1 in particular to the reference and the design for the electronic health record system, and whether that is a subset of health information management system, or what is exactly happening from the perspective of the Ministry of Health and from the perspective of the RHAs in terms of where this thing is going. In terms of, is it that the RHAs have their own solutions that they built, they continue to build them out, and I see a number of things in the press about that, and yet I'm hearing at the stage of design for a record system by the Ministry of Health. Could that be cleared up for me so I have an understanding of the relationship and where exactly this is going and who are the key players as far as the Ministry of Health and the RHAs are concerned? Thank you.
Sure. Through you, Chair. So with regard to the electronic health record, you're correct, member. This is just one component of our health information system. That's one component of it. You're also correct that the RHAs do have some standalone IT applications in terms of health administration, health information systems at this point. Those are, if I want to use the term, interim solutions, and the data that they are capturing will be migrated into this holistic, complete national health information system, which is what Roman 1 alludes to. So where we are with that particular project, we have, together with iGovTT, they are the project managers, and we are currently at the point where we have engaged a consultant through iGov to assist in developing the functional, well, not in developing, in reviewing our functional and technical requirements for an HIS with a view to going out to tender for a solution. We do expect to have that particular consultancy completed by May or June of this year to then go out to market for a solution. The intention thereafter is that once that solution is implemented at the health facilities, the different applications that exist at the RHAs will be migrated into that application. So that will be our National Health Information System. I'm not sure if that cleared it up for you.
It has in some way, and of course, this is getting it to the position of an RFP. And then, of course, the evaluations come back, and then you start work on that solution as it is. So do you have a potential time frame or an outlook as to when you might, coming back maybe to iGov, as to the duration this is going to take, and what is going to happen in the interim as these individual ones continue to happen? Do they continue to grow them? Do they kind of, as development kind of come to an halt? And what is exactly going to happen? Now, I'm looking at this from the point of consumption. You walk into the hospital in Port of Spain, you walk into the hospital in San Fernando. Is there collaboration between the two? Are the records being able to be exchanged? I'm trying to get to the point where what we have in the interim, is it suitable for us to have and maintain where we are for now while we get this thing going? And how long does this interim procedure have to work with it? And how comfortable are the RHAs with what they have?
Sure, thank you. Through you, Chair, again. So let me take the question about timelines first of all. So we expect, having done the RFP, going out to market, done the evaluation, and being realistic, we would expect to start implementation by first quarter of 2022. So in this fiscal year, well, this calendar year, sorry, complete the RFP, go out to market, do the evaluation, identify the funding and what have you, and then start. I want to say also, which I didn't say at the start, that we're starting it in 2 hospitals to begin with, which is at the new Arima Hospital and the new Point Fortin Hospital. Again, they're greenfield sites, if I want to use that term. So we start off there first. The intention being thereafter to start rolling out. Yeah? So that's in terms of the timeline. With regard to the other part of the question, what do we do in the interim? Yes, the RHs will continue to use what they have and maintain an acceptable level of delivery using those solutions as we implement. Of course, when we implement that solution at those 2 hospitals, you'd appreciate that an HIS is modular in nature. So, for example, you have patient registration, pharmacy, bed management, patient scheduling, etc. So there's nothing to prevent us from starting to roll out, for example, the patient registration across the sector, and then thereafter start incrementally rolling out the other modules as we go forward. Yeah. So that's something we have to work on. We haven't clearly worked out exactly what's happening beyond those 2 hospitals. It is a big rollout plan, but it is possible to do it on a modular basis.
Thank you, Madam Chair. And just the final piece on the performance management systems. Is it that we're at the same point with that? And performance management systems in this case being defined as managing the performance of what?
Okay, thank you again. Through you, Chair. So in this instance, we are looking at a performance management system starting at the organizational level and then drilling down to the employee level. Yeah. So that is what is intended in terms of this particular bullet, where we are with developing that particular system. Where we are in that process is that we are through the IDB. We have a loan with the IDB right now, and part of the funding for that loan would be to engage a consultant to develop such a system. What we are doing in the interim, our work is continuing in the interim. What the RHAs have been doing together with the ministry is looking at tweaking our existing performance management system at the level of the employee while we await that holistic review. So it's not that we're not doing anything while that happens. We are looking to tweak and revise within the current environment, and then when that consultancy kicks off, we will then do a holistic overview and overhaul. Thank you.
Thank you, and thank you, Chair.
Okay, may I call on Member Dionarine to join the conversation, please?
Thank you, Madam Chair, and welcome again, everyone. I too want to extend my gratitude to the entire team at all the RHAs and the Ministry of Health with regard to the excellent work and the outstanding efforts that you all have been providing this country with, especially during this difficult time. Now, I just have some follow-up questions following on from what Madam Chair and also Member Bacchus would have asked. I too am having some difficulty in understanding the rate of implementation that you all have established. So my question is it that you all used a particular framework to come up with this map of sub-activities to fulfill the key recommendations coming out of this report? So, for example, what I'm really asking is that, is this map sort of done in a log frame matrix or so using some sort of vertical logic or so on?
Thanks. Hi, Member. Thanks for the question. Yes, it is done via looking at that bottom-top approach, from looking at the sense of what activities were in the RHAs incorporated into the report itself. So we also have a case where activities are mapped against the recommendation as well as the pillar itself. So it's a bottom-top approach that was used to actually gauge the activities together with consultations with not only the RHAs, but also the public as well, to flesh out the broad nature of the recommendations as much as possible, to frame the activities and integrate it into the work plan in terms of and providing a status report on each activity, which then builds up to the recommendation and the pillar itself.
Okay, so then you are telling me that you have clearly defined activities, outputs, outcomes that all roll up into achieving a goal, which is verified by means of verification, right? You have an indicator that verifies achieving all of this.
Well, the method, not all of the means of justification or outcome, but the means of justification was basically looking at the type of recommendation, alignment to the work plan, and the activities in the report itself that align to the pillar itself.
Okay.
As a means of justification.
Okay, I understand. So tell me then something. You did indicate to Madam Chair that you attribute weights to certain things, right? So could you tell me how you determine these weights? Like, for example, one activity or sub-activity may be of more priority or more importance of another. Tell me how you go about weighting these activities. What are the factors that influence the weight?
Well, the first thing was really looking at to see the weighted part was look at on the priorities of the ministry together with the priorities in the report itself. So we looked at exactly, for instance, we look at the infrastructure side of it, was marrying both the constraints from the different factors, whether it be the consultation, whether it be from the report itself, whether it be from the work plan from the ministry. We actually brought all together in terms of highlighting the priority areas within the infrastructure and map it together into one set of sub-activities to support that pillar itself. So there's marrying from not only the report, but from different areas of the work plans and different consultations that were done with different stakeholders together in one, as a means of priority, because the list, as Madam Chair indicated, we don't want to have an infinite list as much as possible, but at the same time, fulfilling the essence and of the report and on the recommendations as well. Okay,
I understand what you are saying, but to facilitate or to help the rest of the committee members, including myself, is it possible? I'm sure that you have some sort of documentation that maps out this entire framework, this vertical logic framework that you are referring to. Is it possible, through you, Madam Chair, for you to submit that document for the committee for our perusal?
Sure, no problem. Yes, it could be available. Yes.
Okay, thank you. Now, I want to move on page 5 of the submission. And on page 5, under pillar 7, primary healthcare pillar, Roman numeral 1, you all indicated that in the first instance, and I quote, in the first instance, there was an upgrade of the operations at the Accident and Emergency Department at the San Fernando General Hospital, inclusive of layout, staffing, equipment, process flow, patient management procedure, protocols, and/or standard operating procedures. So could you elaborate for not only the committee members, but for the listening public, what exactly that included?
So, Madam Chair, through you, so I would probably want CEO of Southwest to maybe speak to what would have happened at San Fernando in terms of what was listed there, please. Thank you.
Sure. CEO of Southwest Regional.
Yes, through you, Madam Chair, for the fiscal period 2019-20, several initiatives were taken in consultation with staff and client feedback. Some may seem operational and granular, but they have had an impact. We have looked at our staffing workflows where we've had dedicated staff positions called medical orderlies. We have rectified issues that would impact respect to transport of patients from ambulance to the trolleys, from trolleys to bed, to wards, and so forth. We have re-engineered our triage and continual process improvement of our best practice. So we do have more staff manning the triage areas that has more efficient triage. We would have done some business flow as well as some, for want of a better word, aesthetics, so that a patient experience is such that you know from simple things like colors of the walls, staff badges, different colors, when you go from triage, when you go to assessment, when you are known to have been assigned a bed, and when it is that, of course, you go to the ward. We would have put in some more equipment, infrastructure, some intercom communications. We would have reviewed again the role of the customer relations officers, speaking with the patients, relaying concerns of patients to staff, focusing on next of kin. So we very much focus based on the feedback with the customer care experience with respect to the re-engineering. So we would have also even done some stock management where we would have been able to create centers. So the flow is that somebody comes in, you assess, you determine your level of acuity, and then you assess in different areas of the emergency department. And once you're determined to be admitted, then you wait in certain areas. So we would have bought more recliners, more patient-friendly recliners. We would have reorganized the bed management system in the emergency department. And we would have also arranged the concomitant stock of consumables and supplies so that the doctors and nurses could administer care. What we have seen over the last fiscal year, even before COVID came on in March, we were starting to see the process improvement. So we use our KPIs as to the number of persons awaiting bed at an 8-hour interval and a 24-hour interval. We also collaborate with the ministry and GMRTT to look at the transfer rates of patients from ambulance to trolley and look at those metrics. And we have seen a very much improved process improvement of those metrics, meeting our SWARA targets and even the targets as desired by the Ministry of Health. So challenges would still naturally remain, yes, when we have some surge, as would have happened post-Christmas a couple of weeks ago. But by and large, those are the specific issues and process improvements. I would say it has been a bit more on business flow and business process re-engineering and some equipment. And well, that is benchmarked against our bed management and the hospital wards, for which we pay a keen eye to the surgical services, and Southwest also has a discharge launch through policy and affirmative action so that we are able to have the continuum of flow. So from the ED to the ward to the discharge, and those metrics are monitored several times a day, literally, with several data metrics. But in terms of answering the question with the ED, those are the specific things in the ED that to elaborate in some more detail.
Okay, so then all of this sounds quite nice, but I want to know, how does that redound to the waiting time that a patient or a citizen would encounter from entering the accident and emergency department to getting attention from a doctor? What it was before and what was your target to achieve through implementation of this recommendation? How much time has it been reduced by? And I'm a frequent user of the Southwest Regional Health Authority facilities, so I can give you some examples where the wait time is nowhere close to at least 4 hours. That is internationally recommended.
Okay, so there has been improvements. Our target time has been 8 hours and 24 hours in terms of the macro times, the strategic look in terms of from the time you come in to the time you get to bed being 8 hours. And of course, we don't want you to go over to another day, which sometimes used to be the case in years gone by, so which we looked at as core markers. We are aware of the patient experience that there are delays. The general is very efficient in triage. It takes a couple minutes an hour. We do have sometimes process delays in terms of getting investigations done. So that is where the couple hours may start to naturally creep up from a patient care experience. So from the time you are assessed, doctors have to run blood tests, or they have to do x-rays, or they have to do CT scan, the popular sort of imaging tests. That may have challenges. We have had some instances where you may not have all equipment function optimally at all times, but for the majority of times, that is what tends to occur. Critically ill patients are generally seen very quickly. Those who have life and limb-threatening injury, we tend to have patients who fall into the categories of what we would call medium risk, in terms of medium risk, so like heart attacks, strokes, and so forth. Those patients tend to, relatively speaking, to the critically ill would have more wait time because they have to get more investigations done. But at the same time, noting that reality, we have seen the improvement. And then beyond that, once you get the investigation and a definitive diagnosis, well, then you now have to await getting to the ward. And as I said before, we have improved your comfort level while you may have to wait in some instances in the emergency department to get to the ward. So whether it is a bed in the emergency department area, or whether it is, once you're not as critical, you may get into our patient-friendly recliners. And well, as I said, we focus on the orderlies. So I do know that there are outliers, that some patients describe a longer waiting time relative to others. We do have customer relations officers on the floor, and all of us as executives and managers, anyone can reach out to us from ministry straight down to the patient. And once we get a call or a WhatsApp message, we certainly try to resolve individual requests. But looking at the health system as a whole, there are process improvements in terms of the data analytics. In terms of our key marker is time to be triaged and time to get a bed if you need a bed.
Okay, Madam Chair, if you allow me to continue, I have 2 more questions pertaining to this matter.
Yes, you may.
Thank you. Mr. Moore, could you tell me then, what practices has been adopted in the waiting area of accidental and emergency in terms of making sure that patients who are waiting attention adhere to COVID-19 protocols? Because I was there in early January and everybody was, in local parlance, stick up next to one another. It had nowhere where we were at least the recommended distance apart. So I saw the 2 recliners that you were referring to, but there were at least 12 persons inside there, and I counted, and everyone was next to one another. There was no social distancing. And also, my question to you then is, what is the nurse to patient ratio and the doctor to patient ratio? Because I didn't get attended to when I entered accident and emergency. I waited 3 hours and I left because the issue was so severe that I had to go and seek private healthcare somewhere else. So tell me, what is the average time from entering there and receiving receiving attention from a doctor? I know you said it's depending on what type of service, what type of disease, or what type of threatening illness that you may have. Also, give us an explanation as what is considered low risk and high risk, because you alluded us to what is considered a medium risk.
In terms of the actual numbers of the doctor-to-patient ratio, as I said before, we have 250,000 encounters per year across our 5 emergency departments. San Fernando Emergency Department, in particular for 2019, we had about 92,200 encounters over a 12-month period. I say encounters versus patients because patients may obviously come in more than once depending on the chronicity of their condition. But in terms of our staffing complement levels, it is never 100%. I know of an overall, for example,
Mr. Moore, you're muted.
Oh, I'm so sorry. Okay. Yes, I was saying that in terms of our encounters, it's 92,000 for San Fernando General Hospital patient encounters, as opposed to, because a patient may encounter the service more than once. In terms of the nurse and doctor to patient ratios, well, then we would measure in terms of, we look at the amount of doctors that require to man the areas per shift. Generally, the medical staffing is adequate. Sometimes we may have challenge with nursing shortages, intermittent, but that is managed departmentally. The medium and risk, I was speaking in lay terms, in terms of there is an established process of triage, as we call it. It's based on a Canadian system where patients are assessed as most critical as level 1 and not as critical or very low risk, what you call, it can walk into the ED then rather than being trolleyed in or carried in as level 5. So generally, level 1 and level 2 are very critically ill patients. Those are patients with like gunshot wounds and at risk of dying from whatever complications, severe heart attack, they come in semi-conscious. Those patients are generally seen immediately and of course managed immediately. And once they survive their acute illness and stabilize, they go to the ward. Level 4 and 5 are those patients who are generally able to walk in. They prefer to access healthcare at the emergency department. They believe based on their health condition, they need treatment. Most of those patients tend not to be admitted after assessment, but they are counseled appropriately, given medication if warranted, or if there are any minor surgical, like basically cuts and sprains and strains of joints, those sorts of patients are seen. What we find is that it is what I call the medium risk, really our level 3 clients. They are not well enough to go home, but they're not critical enough to need immediate attention, but they would need some days on the ward. And those are the sorts of patients that would generally those who have chronic disease, and nationally chronic disease brings a lot of complications to your organs. Those are the patients, when we look at our analysis, those are the patients that I'm very mindful and aware of the length of time it takes for them to be seen. They're anxious, their relatives are anxious. But I just elaborate a bit because in the scheme of things, that's the wide spectrum of patients that come to the emergency department. So we're very mindful that those level 3, what I called before medium risk, those are the patients that take the time. They require investigation, whether it is blood tests, whether it is x-rays, and they need multiple reviews. So they would need review by the emergency doctor, by the specialist doctor, and decisions are made collaboratively. And that generally does take some time in those instances.
Okay, thank you. So generally, tell me something. How many doctors are usually working in accident and emergency at any particular shift?
I don't have that precise answer, but I would probably ask for assistance from my director of health, Dr. Ramata, because we do have both specialists, senior doctors, registrars, and even house officers who work in the department. But I would ask my director of health to add clarification to your question.
Thank you.
Madam Chair, through you. So on every shift, we have one SMO, 2 registrars, and approximately 8 house officers. The officers, you have 1 registrar would be in what we would consider to be a trauma section, devoted to dealing with the acute injuries and so on, and another one in the general non-trauma area. The officers are deployed according to the severity. So you will have some in what we call the resuscitation room, dealing with the acutely ill, and then you have some, there's a filter clinic for the what we'd call the level 5s, level 4s and 5s. So you would have 1 or 2 officers there, and the others would be dealing with the level 2s and 3s. That is, so the staffing is really deployed according to where the risk is.
Okay, thank you. Madam Chair, I would pause here.
Thank you very much, and I want to really tell all other members who've been waiting that I do appreciate their patience. I will therefore call on Member Mark, after Member Baselami, and then Dr. Bodo. So Member Mark, thank you.
Yeah, thank you very much, Madam Chairman. Madam Chairman, let me join you and my other colleagues in extending my appreciation to the various RHAs and their leadership, and of course the personnel who have been doing human service in a very difficult period in our country's history. So I would like to join you in extending my compliments as well to the people who are with us today. But Madam President, there's no doubt that the healthcare system seems to be broken. Like the criminal justice system in our country, there are challenges. And I think that to overcome those challenges, we have to face reality. And in this context, I wanted to ask the CEO of the North Central Regional Authority a few questions. Now, Madam Chair, through you to the CEO, and I would like him to correct me if I'm wrong immediately. I did write that in terms of complaints at the North Central Regional Health Authority, we got a percentage of 66%. Is that right? Madam Chair?
No, through you, Chair, Madam Chair. There was a decrease between 2018 and 2018 and 2020 to the tune of 66%. So we had a decrease in complaints. We also had an increase correspondingly in commendations of 30%. So there was a decrease in the complaints simultaneously with an increase with corresponding increases in services and simultaneously an increase in commendations.
Well, I am very happy for this institution for having received from your own assessment and analysis 66% based on your scientific work. The query I would like, or the area I would like to clarify, I am sure that you are familiar with a headline. It was a glaring headline in the Trinidad Express, 17th of January, 2021. Hospital horrors, fed up of waiting. Now, this was on the 17th of January, 2021. So it tells me that something is not synchronizing well at the NCRHA. Because if you have citizens complaining, I want to tell you, whilst myself, if I go there, I know you, Mr. Davlin Thomas, will look after me and give me top attention, and anyone of my family. But I am not concerned about me. I am concerned about the ordinary citizens who were complaining vociferously about the length of time it takes to even get an appointment. And when they get the appointment, it is just kicked down the road like the bucket or the football. And they keep going. Some talk about 8 months, some talk about 1 year, some talk about 2 years. Now, that is extremely frustrating. Do you have data or statistics to share with this committee as it relates to the number of citizens who might be in that category where they come in and they have to be religiously and faithfully postponed or receive a postponement after a postponement after a postponement? Is there any data you can share with us as it relates to the number of citizens who access your healthcare who might be involved in that kind of waiting exercise? Mr. Davlin Thomas?
All right, particularly through you, Madam Chair, particularly during the COVID season, as we call it, and in particular particular as well with surgical patients. If you remember the complaints that emerged in the newspaper on that day, they were particularly surgical patients. The patients who required care for chronic diseases, heart disease, diabetes, and hypertension, and so on, we were able to engage them directly via the telemedicine services. The surgical procedures in particular required one-on-one interface and interaction. Now, if you recall what was taking place as we traversed the COVID-19 engagement, there were regulations that would have changed from time to time that would have identified and stipulated for us just how many persons can be within a confined space, and which eventually went down to some, at times, just 5 persons. The net effect of that is that for surgical patients in particular, we would have had periods when we, for the non-urgent surgeries in particular, deferred some of those patients to subsequent appointments. I don't have the exact number of those patients before me now, but we do track them, and we have been engaging them.
Would you be kind enough, Mr. Thomas, to provide to the chairman of our committee data on the amount of postponement that has taken place with patients who are seeking what you call non-surgical operations, as well as those who are seeking surgical operations within your institution? So since you don't have that data, and I can understand that you won't work with everything, but so could you provide that in writing for us? The second area I would like to share
Member Mark, just so that, please allow me to intervene, just so that we are clear with what we're asking Mr. Thomas to provide. Over what sort of period? We're looking over the last year for that sort of information?
Well, Madam Chair, I'm looking at the period of implementation of the Welsh recommendations. That is a period to the present, and they began to implement in 2018.
Good. So at least you're looking from 2018. Yes?
The current time. Yeah. The second area, Madam Chair, through you, I'd like to ask my colleague and friend, Mr. Davlin Thomas, is could you supply this committee with information concerning the number of, let's say, patients who access medical services, healthcare services at the North Central Regional Health Authority on a total basis? When I say total, I should say on an annual basis. And if you were to go down to a subset, which is the Eric Williams Medical Sciences Complex, could you also share with this committee the number of citizens who would access healthcare on an annual basis at the Eric Williams Medical Sciences Complex? Do you have that information? If not, you can put that in writing as well.
We have some of that information here. We could, for example, primary care would see at least over 600,000. That's the impact during the fiscal. For Eric Williams Medical Sciences Complex, the emergency department would see at least 8 new patients per hour, which is about 4,500 to 600 patients monthly. That's just the emergency department. What we would have is a breakdown of each department, but our catchment is about 400,000 or so. The net impact at the facility is basically approximately about per month, anywhere between 100 to 300,000 visits, patient visits. In particular, our pediatric department, we see somewhere between 40,000 persons a year to 2,900 patients monthly. We're looking at every hour, at least two children come into the department. Our inpatient admissions, every single day at the Eric Williams Medical Sciences Complex, we have about 70 patients admitted daily. That's 2,137 patients admitted to ward on a monthly basis. This is over 25 to 28,000. This is per year in terms of inpatient admissions to the ward. So just to give you a sense of the magnitude, our clinics, we see 9 visits per hour, about 75 visits daily. We see between 27 and 41,000 people within the year, persons. This is in only in our medical clinics. Our surgical clinics can go anywhere within a year to 66,000. We're talking about 16 patient visits per hour at a 126 visits per day, and the outpatients for pediatrics are about 20,000 children per year. Our surgical procedures, as I told you, they range between, and this is 18 surgeries per day at a rate of about 8,000 to 6,000 to 8,000 during a year. Our diagnostic lab does about 289 tests per hour. That is 6,944 tests per day. This is every single day we do tests on our lab for 6,944. That's 2.5 million blood tests done every single year at a rate of 200, nearly 300 tests per hour. Our radiology procedures are just the magnitude of the throughput, I think, is clear now.
Yeah, Mr. Thomas, that's why I complimented you and all our colleagues who are with us today on the kind of work that you all have been doing. What I want to get from your good self is whether you can provide our committee with some kind of data that would really reflect not only the numbers that you do in terms of seeing people in the different areas that you have identified, not only the number of tests that you have conducted, but if you can share with this committee how many people out of those many tens of thousands actually receive what you call the kind of active, positive, and sensitive service, so that at the end of the day, they get their tests, but within, for instance, a couple of hours, they get their results. And if they said, oh, look, this person has gallbladder or gallstone, you need to have an operation. How many people, from a statistical point of view, you would say are able to get not only results not only to take tests of these people, but to get actual results at the end of the exercise so that they could walk out feeling happy? Do you have data on that so you can show that, look, 10,000 people visited Eric Williams, break it down, how many came for this, how many came for that, and at the end of the year, so many of them were given first-class treatment and they left. Do you have data on that?
Well, we have two kinds of data that could lead you to some conclusions. One is that, for example, some of those value-added processes like the lab, when you come into the lab, those 289 persons, they receive, for example, they may not all be at the go to the lab. They may be at the emergency department and so on. And just to give you an idea of some of the innovations that took place within the recent past, when you go into the emergency department, prior to last year or so, there were situations where you would go into the lab, the emergency department, we would have had to take blood tests. When the consultant does come around to see you, your blood results may not have been, they may either have been ready and not issued to the emergency department at that time. There's a lot of talk, discussion earlier about the HIS system. What we did was we did our own homegrown lab information system. And I'm speaking now not just to the test, but the value of distributing the information from the test or the test results directly to the places that it needs to go. So we created an homegrown through our ISIT department and lab information system. So when that patient, that test is sent directly to the lab every half an hour, the results now are sent immediately via computerized system to the emergency department. The net effect is that when that consultant does arrive at the emergency department, the information is now available. The net effect of that is a decreased waiting time for that patient in that department. And that's just one example of the innovations. We've spread that system to the wards as well. So the lab information is now available and distributed to the wards, clinics, etc. So we've managed now.
Thank you, Mr. Thomas. Yes. I want to thank you very much. And if you could commit the rest of your reflections in writing, we'll appreciate it, because time is of the essence for us, and we have to leave at a certain time, and you too. Let me just ask you another question. Mr. Sawyer-Fat, is Mr. Sawyer-Fat the CEO of the Eastern Regional Health Authority? Yes, I think so.
Yes, yes.
He made a very powerful contribution when he was speaking earlier, and it caught my attention. He says that at the Eastern Regional Health Authority, they conduct annual feedback surveys, and that is to get a feedback from their customers, the patients who visit that Eastern Regional Seaboard as it relates to the RHA in this instance. I would like to ask Mr. Gavlin Thomas whether at the North Central RHA, there is a similar annual feedback survey in effect.
Well, yes, it is. In fact, it's consistent within the entire RHA system. So we do have those quality feedback surveys. But in addition to that, we would have been measuring, for example, our waiting times that are consistent with international standards. For example, the discussions that you would have had before about the CTAS in the emergency. We were able to decrease our waiting times that were initially in 2018, 2019 at 1 hour and 50 minutes in at least level 2 to 38 minutes. And for example, level 3, 78 minutes. So these are things that we track. But in addition, we've also had recently our mystery shoppers who entered the system to give us a clearer picture of what was happening inside of the within the services. So, but the client feedback is consistent throughout the sector.
Mr. Thomas, could you provide to the committee a copy or documentation on your annual survey plans in terms of, what the results have been and what has been, in other words, on an annual basis you conduct it. So we would like to have documentation to that effect from 2018 to the present time. I'd now like to ask, Madam Chair, a question to the Chief Medical Officer.
Okay, so Member Mark, might I ask that information? I would think we would want it for all the RHEs, seeing that the practices are supposed to be consistent, the policies.
Yes.
Okay. Yes. All right.
Yes.
So you,
Madam Chair, I'm going to just ask 2 questions, and then I'll pause for a little while and allow my other colleagues to come in, with your leave, of course. This question deals with Pillar 6, and it deals with the Office of the Chief Medical Officer. I do not have to regurgitate what the Welch's committee had recommended, because the medical personnel who are with us and the administrative staff would be aware of it. But I'll just say briefly, one was to reestablish the Office of Principal Medical Officer in areas that have identified epidemiology, environmental health, institutional strengthening. And of course, to have a better reporting, strengthening the reporting relationships between the Ministry of Health and the RHAs. So the first question I'd like to ask here, and maybe that will go to, as I said, the CMO, as it relates to the reestablishment of the principal medical officer positions in the areas of epidemiology, environmental health, and institutional strengthening. Can you provide this committee with a status report briefly, and then you can put it in writing thereafter?
Thank you, member. So in terms of when I began as CMO in January of 2017, there were none of the positions reestablished. We quickly went to and had meetings with the DPA with regards to reestablishing based on the need and what was in the Welsh Committee's report. So there were 4 positions that needed reestablishment: the Principal Medical Officer of Environmental Health, Principal Medical Officer of Epidemiology, Principal Medical Officer of Institutions, and that of Community Services. At the time, there was suppression of the Community Services post in lieu of another post that was in the Ministry of Health for a Senior Technical Officer, and that person had just started a contract which was lasting 3 years. So we were able to, I think, advertise the positions of EH, epidemiology, as well as institutions during that time. And we were successful in actually appointing 2 persons to the post of environmental health, I believe in either 18 or 19, and epidemiology would have been thereabouts just a little while after the environmental health positions. So we have 2 appointed officers in the epidemiology post and in the environmental health post. There's 1 acting officer at present in the principal medical officer institution post. I think we would know that person as Dr. Richards. And in terms of the CS post, now that the person has demitted office from the technical advisory position, Cabinet would have agreed that we can now advertise through the DPA the position of PMO CS, which we have liaised with the DPA, and hopefully that position will be advertised soon, together with although the PMOI position was advertised in the first instance, DPA may decide to re-advertise based on the number of persons that were shortlisted was quite small. So there may be re-advertisement of both the PMOI as well as the PMOCS position, hopefully in the near future, so we can have all 4 PMOs in the Ministry of Health. Just to say that the positions, I would have been about 6 to 8 months as the CMO without those positions in place. And I think the addition of the PMO's position to support the CMO has gone a long way and assisted, especially during the COVID-19 pandemic, to give us that needed support in the office of the CMO. I hope that suffices by way of an update.
Yes, thank you very much, Dr. Prasa. I'd like to ask the Permanent Secretary Acting in the Ministry of Health this question. What is happening with the strengthening process for insofar as the reporting relationship is concerned between the Ministry of Health and the various RHAs? Maybe the Permanent Secretary can come in here and tell us what is the current status of this particular matter.
Sure, thank you. Through you, Chair. Thank you, Senator Mark. So with regard to the reporting relationship, we do have various mechanisms in place, one of which would be we have quarterly meetings of the quality managers of the RHAs together with the Ministry of Health Quality Department. We do have the adverse events reporting mechanism, where if there are adverse events, those reports come back to the ministry. We do also have regular reports coming in through our health policy and planning department, and also our epidemiology department, where we will get statistics in terms of patient throughput in various areas from the respective RHAs. In addition to those formal mechanisms, We also meet on a monthly basis with the chairman of the boards, the respective boards, together with the CEOs, minister, CMO, myself, the DPSs, and there's also a weekly meeting of the CEOs and the ministry's executive. So there are quite a few different mechanisms in place for reporting between the RHAs and the ministry.
As I have you on the floor, can I ask you to give us an update on the whole issue of the C-store, or C-stores as they call them? You know, there has been this whole question about its over-centralization and the accompanying bureaucracy, which causes a lot of confusion in terms of RHAs accessing medical supplies, pharmaceutical products on a timely basis in many instances, not to mention shortages of supplies in critical pharmaceutical products. Can you advise this committee whether any attempts are being made to relook at this over-centralization and bureaucracy and move towards a more decentralized approach so that there can be more efficiencies generated if you have a greater level of decentralization rather than the over-centralization that we currently have?
Sure. Through you, Chair. So what we have currently would be the centralization of the procurement function for those medical supplies that you spoke about. And that is, in essence, what is centralized, the procurement function. The RHAs each have point persons, as well as NIBDEC, who, as we are aware, would be our procurement manager for our farm and non-farm supplies. So there's a point person at the level of the RHA, as well as NIBDEC, and they interact on a literally daily basis sometimes with regard to managing that supply chain and logistics between the RHAs and the NIBDEC central stores. There's also a dedicated resource within the Ministry of Health that is also works together in terms of that particular network. So in terms of an over-centralization, I don't think that is currently the case. What is centralized is the procurement, and for obvious reasons. In terms of economies of scale, taking advantage of the supply chain and stuff like that. But beyond that, I think the decision-making process and the whole supply chain and logistics function, it is decentralized to a large extent across the sector.
So you would say at the present time, things are working relatively, things are working relatively good, you would say, at this time?
Well, there's always room for improvement. There's no perfect system. So we are continuously looking at ways to improve what we have. But things are working well.
Relatively efficient?
Relatively well, bearing in mind the current environment within which we operate in terms of global supply chain. With COVID, that has affected supply chains globally.
All right, Madam Chair, I will pause at this time because I know I've taken up a few moments. Well, I have a host of other questions, but I know time is running out on us, and I'll pause at this time. And thank you very much for allowing me to intervene at this time.
Okay, so can I call Member Bartholomew, please?
Good afternoon, everyone. Good afternoon, PS. Good afternoon, CEOs. Good afternoon, Madam Chair. I'm sorry. Good afternoon, CEOs. Good afternoon, COOs. Good afternoon, heads of departments. Thank you so much for joining us. Madam Chair, through you, I have 3 questions to ask. But before I continue, I just have to say that I disagree with Senator Mark. Our healthcare system is not broken. I believe we need or we require improvement, but my father recently suffered complete organ failure in October, and he was admitted to the Port of Spain General Hospital, and because of their care, he's alive today. So thank you very much. So my first question goes to PS Ali under the pillar under pillar primary care, under the primary healthcare pillar, right? Item 3. The system for block appointments has been instituted across some specialties, and the system is currently being assessed to determine its effectiveness. Can you explain for the members and the wider public what this system does?
Thank you. Through you, Chair. Now, I know you posed the question to me, but maybe I could pass that question across to one of my technical persons who would be better placed to explain what a block appointment system is. I'm not sure, CM, if you want to take that, please.
Yeah. So basically what used to happen in the past, and you would see it a lot in the primary care setting, is that persons will come in, people would be asked to come in at a certain time when the clinic begins, sometimes between 7 and 8 a.m. in the morning, and all 30 or 50 people that were registered for that particular day will show up at the same time. What it means is that somebody on that list will end up having to wait quite a long period of time to be seen, possibly half of the day. So by way of block appointments, what you do is basically schedule your appointments every hour or thereabouts so that persons come in throughout the day. Usually it goes, for example, 8 a.m., 9 a.m., 10 a.m., 11, there's a break for lunch, although the patients are continuously seen during the lunchtime period, and there's rotation of staff, and then of course resumption at 1, 2, and 3, for example, in a health center setting. So that has been used across the board for a long time in the primary care setting. It has begun to be used in North Central and other RHAs in the secondary care setting as well, and it really is meant to decrease the length of time one person will have to stay in the clinic, and of course get best use of the staff in terms of staff being able to see you in a staggered manner and giving that appropriate length of time for the physician consultation to occur, rather than trying to do an ad hoc scenario where the consultation is really disadvantaged and you're rushing through from one patient to the next. So the block appointment has been doing well and established for quite a number of years, and the expansion into secondary care has started for certain RHAs, for example, North Central, because of constraints with the size of their clinics, because Central Block, for example, is down. It hasn't gone as much as into the block appointment system as, for example, North Central or Southwest would be able to in secondary care, but it is a policy that we hope to roll out across the system so that we can see, and redounding really to patients coming in at staggered times and spending less time to be seen by the physician and having a better patient experience at the end of the day.
Thank you. Through you, Madam Chair, my second question goes to Mr. Thomas. On page 7, item 3, the NCRHA has been utilizing a system approach to facilitate the positive outcomes for improved service delivery by conducting audits, gap analysis, and identifying action plans, basically to improve service delivery. Can you elaborate on some of those gaps that you identified and how has it improved your service delivery?
Through you, Madam Chair. Well, just to explain what the system of approach is that we're particularly interested in a more holistic sense of how things interact to facilitate the outcomes. So, for example, one of the examples I gave earlier was the relationship between being able to have a lab result available for the consultant when he gets into the emergency department, and to be able to do that in a predictable manner, so that it would then imply that the patient could then be discharged the very same day. And another gap that we would have had is, and this is just another example because we have multiple. One is, and just using the emergency department as an example, for a patient who came in with the possibility of a heart attack, chest pains, etc. It's important to do a test called troponin. Usually a troponin test would take about 12 hours in the past. The net impact of that is that you will have to retain that patient in that department for the duration of the 12 hours and therefore generate additional congestion. So you could just imagine in the past, if you would have had 5 or 6 or 10 of those patients with the possibility of heart attack staying each 12 hours. With the approval of the ministry and the board, we started from a systems approach, purchasing what we call a high sensitivity troponin machine. That reduced the time that it takes for the test to just about 2 hours. The net impact of that, and if you multiply that by numerous patients, that we were able to tell immediately that in 2 hours that you whether you had a heart attack or not. The net impact is that if you didn't, then we could send you home. And the implications of that, the outcomes are less waiting times in the department, less congestion, and certainly the patient improvement in the patient satisfaction. So those are some of the examples of what we term systems approach, and the gaps that one or two of the gaps that may have occurred.
Okay, thank you so much. Madam Chair, through you, I have one last question under the pillar infrastructure and medical devices. This goes to either PS Ali or Mr. Moore or possibly Mr. Allen. The ministry will seek to commence construction work for the establishment of a cardiac catheterization lab in the San Fernando General Hospital. What does this mean for the general public?
Sure, thank you. Chair, maybe Dr. Moore can speak to the clinical benefits of having this cath lab at the San Fernando General Hospital.
Sure, thanks for the question. If through your chair, I think the Director of Health as our content technical expert, and he himself is a senior cardiologist, so I would like you to answer.
Thank you, Madam Chair. So cath lab is designed to rapidly diagnose if someone has blockages of your arteries. Ideally, it should be close to your accident and emergency department. Your patient comes in with chest pains. You suspect a heart attack. You get them into your cath lab. You look at their arteries and diagnose if they have blockages. The standard treatment for heart attacks now, a particular type of heart attack, is to go into the artery and open them up and put in a stent. And that saves lives. It saves a whole lot of downtime for the patient, as well as ongoing costs for continuing medical care for the patient. So the impact of it would be a quicker diagnostic time for your patient, shorter hospital stay, and reduce long-term complications. Long-term, it saves the government money if this equipment is close to your accident and emergency department, and you have a program of doing rapid diagnostic work and intervention.
Okay. Thank you so much. Thank you, Madam Chair.
Okay, thank you. May I now call on Member Bodo?
Thank you very much, Madam Chair. I just want to tie my next question back to the primary healthcare system and related to the improvements in the triaging system and the ambulance management at the accident and emergency department of the San Fernando General Hospital. Widely recognized as one of the busiest hospitals in the country. And I'm happy to see that we are building and so on. But if I might direct this question to Dr. Moore, CEO, I just wanted to ask, and I asked this in relation to a recent incident that occurred at the Point 14 area hospital, where there was an issue with triage, and it's reported in the newspaper of Monday, 1st February. I don't want to go into details, but it's related to a patient, Carol Joseph Alexander, with either the institution. And there are a couple of issues there that perhaps you may want to address. And I'm sure that you probably have an investigation already commenced into this. But one is the issue of triage that came up in the when the patient was being asked to go through a second triage despite already being admitted and sitting there with chest pain. So perhaps you may want to share some clarity on that. The other was the issue of the patient having to be transferred to San Fernando Hospital because she required intervention of a cardiac nature, transpired she had a heart attack eventually, and the absence of an ambulance. And I also want to tie this in because I note also in the infrastructure pillar that that the Point 14 hospital is now on stream. So if I can just ask Dr. Morcio, if you can just give us a brief update as to whether the training and the improved system at San Fernando, has been shared with those at Point 14 area hospital.
Madam Chair, thank you for the question. I'd like to take the opportunity to express condolences on behalf of Southwest Regional Health Authority to the family and friends of the deceased patient. Yes, I am aware of the situation. The matter is under investigation. We are due to complete a report based on my last check on Friday, the 12th of February. So it's being actively investigated. Through the adverse events policy, it would be determined to be classified as an adverse event. Once, based on the policy framework, once we have incidents like this, it is investigated. There's an RHA committee that determines if it is an adverse event, and then that, of course, requires, through the policy of the ministry, certain actions. The triage system, as described, is in place at all 5 emergency departments in the Southwest Regional Health Authority. And speaking of San Fernando General, our 3 district health facilities, which are at Siparia, Couva, and Princeton, and at the area hospital Point 14. So yes, part of the investigation is looking into the triage system that is already enshrined, and therefore any gaps or deficiencies, either in this individual case that may involve particular individual officers, or if there's unearthed a more systemic issue that was not seen before, then that would be addressed. But in terms of, based on the volume throughput that I have mentioned earlier, in large measure, it's a pretty standard process. So any gaps or any issues that arise or come in the public domain, we promptly investigate. In terms of, so that is in terms of the level of expected training and competence, as well as the system that is in effect at our 5 emergency departments. Sorry, through your chair, Member Bodo, I believe you're on mute. Sorry, I'm not hearing.
Thank you. CEO, can you hear me?
Yes.
Yes, so I was asking for the benefit of the public, can you indicate what services are currently available at the Point 14 hospital? So I'm speaking of the new Point 14 hospital.
Okay, well, the new Point 14 hospital, it was commemoratively opened in July, and we started outpatient services in August, which are our outpatient clinics. We are working with the Ministry of Health and other stakeholders. We are in the final processes of commissioning all the equipment in order to have a full transition of services. So it would include the services that are currently at the old area hospital, which are our emergency department services and our general medical and surgical services. As illustrated in the public domain, there are significant and new services at the Point 14 hospital that basically are in keeping with the standards of practice for any modern hospital. So there are CT scan services, there are enhanced new services such as burns unit and ophthalmology services, and a lot of quite impressive support services as well. So the range of services in terms of in the next immediate phase, right now we're doing outpatient clinics. Then we are going to move across existing services, which are the ED, emergency department, lab, basic and advanced radiology services, and our ward and theater services. And then certainly shortly thereafter, with the additional equipment, we do intend to fully utilize the hospital in terms of how it has been built at installation.
Thank you, CEO. Do you have a time frame for the transition of these services from the area hospital to the new hospital?
We are working with through the Ministry of Health. Our optimistic forecast is at the beginning of March. We can't say that we are at the final stages, having our own internal process monitoring of the commissioning. It is a complex sequence to ensure that the equipment, quality assurance, staffing, training, everything else is lined up such that when we open our doors from day 0, day 1, however we look at it, patients get the quality care. We are looking at early March.
Thank you. In terms of staffing, is it the intention to allocate staff from the other hospitals, or is it the intention to hire new staff for that facility?
Based on the commissioning activities, there has been planning with the ministry in terms of dedicating an operating budget for which we were already allocated. And is of note, in noting what the CEO of ERH said, we were in the process of hiring persons in the middle of COVID last year in preparation for the opening of Point 14 Hospital. And we are talking here about bringing on board between the existing on around 272 staff at the area hospital. We were in a position to hire on around, I think a little over 300, close to 400 persons. So we actually did hires during the midst of COVID, while COVID is going on, through our tele-interview process. And therefore, we have the budgets additionally applied for the commissioning of Point 14 Hospital. So those hires have since been completed, and we have done the staff training and onboarding. So therefore, we have the staff ready to be deployed to offer service.
Thank you very much to you. If I may, Madam Chair, just to move on, just a few of the vertical services. And these are mainly on page 12 and 13. And perhaps I can share these questions between the PS and the Chief Medical Officer. I wanted to just get an update in terms of the blood transfusion services, the National Blood Transfusion Service. And I know the goal of trying to achieve 100% voluntary donations. But there are several issues here. I know that there's a terms of reference for the National Blood Transfusion Service, the clinical protocols, and the appointment of a medical director. So I don't know, PS or CMO, whether you'd want to give us an update, and the public as well, as to where we are, blood transfusion being such an important and necessary service in terms of saving lives. If we can have an update as to where we are with the National Blood Transfusion Service.
Sure. Through you, Chair. Let me just speak to the administrative parts of it quickly, and then CMO can speak to the technical parts of it. Remember, you mentioned the CIVA director. So we are currently engaged in the recruitment process for our director. I hope to have that completed during this month and to have somebody on board by the end of February. All right? That's in terms of the leadership of the blood transfusion service at our end. I will let CMO speak about what's happening throughout the sector. Thank you.
Thank you, PS.
Okay, so in terms of the blood transfusion service, we currently have no sitting director. However, the consultant hematologist at Port of Spain General Hospital has agreed to provide oversight, and she has been at the blood bank before. She is presently there providing oversight by phone through round the clock, as well as sitting in 2 days a week to the blood transfusion service, and she is very close by as the consultant in Port of Spain General Hospital. By way of the systematic issues at the blood bank, we had Dr. Waveney Charles, who was in the blood bank, hired as a consultant a couple of years ago, and her purpose was really to develop standard operating procedures to ensure that they were robust and in alignment with international best practice, which she did. And she has handed that over to the Ministry of Health. So we're in the process of implementing countrywide the standard operating procedures for the blood transfusion services. There's a somewhat decentralization of the donation site. So now all the RHAs have their own blood donation centers. We retain the National Blood Transfusion Service for our testing for pathogens, dangerous pathogen screens, as well as in some instances, we do some breaking into constituent parts of the blood process, for example, platelets. We are looking towards the blood transfusion service has also been overseeing the quality improvement arm of it through a national committee that has been set up to go towards a full voluntary, non-remunerated service. Hopefully, the process is earmarked to take approximately 3 to 5 years to go from a chit-based system all the way to a voluntary system. And that unit is actually chaired by myself with the blood donation nurses from across the country, as well as a corporate communication unit. And Dr. Kenneth Charles is also a technical advisor on that particular committee. The other bit in terms of quality control across the RHAs, we have re-establishment a couple of years ago as well of the clinical blood units at each RHA. So they now have a clinical committee designated to the use of blood and blood products to decrease the amount of wastage and to streamline the clinical distribution of blood and blood products throughout the system. So in terms of our service, I think there was great improvement over the last few years. However, we are still searching to get a director, which is a big piece of the puzzle. Once we get the director in, we can have enhanced monitoring of what is happening at the RHAs in terms of the utilization of blood products, as well as the donation centers, and trying to get that voluntary blood donation up to 100% in the next 3 to 5 years.
Thank you, CMO. I'm happy to hear PS indicate that perhaps we'll have a director by the end of February, because I know there's a shortage of local hematologists in the country. Can you indicate whether citizens can donate blood at the RHAs on a Saturday? I know it's convenient, and I know there was a practice at SWRHA some years ago. Can you indicate whether that is still possible?
So each of the RHAs have a particular blood donation center. I know we have expanded the hours in recent times. I don't know if the CEOs can let us know, maybe individually, if I believe we had gone to half day on a Saturday or up to 2 p.m. in some instances. The CEOs can give us an idea of the actual hours of opening of the blood donation sites under their purview.
That would be useful. Thank you, CMO.
To you, Madam Chair. It's for the NCRHA, our blood donation site at Eric Williams is open on Saturdays now till 2. And so it's really just to confirm that.
Can we have for the Southwest Regional, please?
Yes, subject to confirmation of the precise open hours, we do open on Saturdays up to half day, as I'm advised.
Thank you. And what about the Northwest?
Hi, good afternoon, Madam Chair again. Yes, we are open on Saturdays as well from 7 to 2. And we also have our mobile blood clinic that we go to different communities for blood donations as well.
Thank you. And East Regional.
Yes, Madam. Our blood bank services run on Saturdays till 12 noon. And we also have the supplementary blood drives from time to time.
Thank you very much.
Thank you. Yes. Madam Chair, if I may, so I just wanted to raise the issue of dental services. Very important, but the public health dental services really in need of some work, and I see that part of it is spoken about here. CMO, perhaps could you share with us the plans to decentralize the dental health services and what we can expect when these recommendations are fully implemented?
Yeah, so as you know, with the coming of the RHA Act, the intent of the spirit of the Act was to have all clinical services delivered to via the RHAs, and of course, Ministry of Health retain the strategic vision and the policies arm of it. So dental services is one of those purely clinical service delivery arms. Of course, the ministry has a role with regards to policy, but with regards to the clinical service delivery, we see and we agree with the recommendations of the report that it should be delivered through the RHAs as do other services occur. And we are in the process of actually doing just that, having that service decentralized so that the clinical service delivery will be through the RHAs. There's a human resource component to that, meaning, and I think the PS may be better suited to answer what is going to happen with regards to the Ministry of Health dentists that are retained with us in terms of going towards the RHAs. But I think that will be the last part of the puzzle where the remaining persons, maybe dentists and other officers, are going across to the RHAs to complete that decentralization process. I don't know, PS, if you want to add anything.
Madam Chair, I would like PS to have an input here.
Sure, thank you. Through you, Chair. So, Member CMO is correct. So in terms of the HR element, excuse me, what would be happening during the course of this fiscal year, we would be handing over the management of dental services to the respective RHAs. The intention being that the RHAs would come up with their respective structures for the delivery of dental services within the respective RHAs, within the ministry's overall oral health policy. With regard to the staff that are currently employed by the ministry, the dentists and the dental nurses and assistants, just like the other public servants when the RHAs started, they will be offered the option to transfer to the RHAs or to access VSEP. And depending on the option that they exercise, we will then take it from there in terms of if they choose to transfer to the RHAs, they'll move across to the respective RHAs. If they choose VSEP, then the RHAs are free to hire persons in those vacancies. But there are existing vacancies currently, and the RHAs are free to hire persons in those vacancies. And that is what we're working on right now to hand over to the RHAs.
Yes, thank you. Can you indicate how many vacancies, if you have that information, are there for dentists in the public health sector?
I don't have that with me right now, member, but I can provide that to you in writing.
And thank you very much. If we can have that in writing, Madam Chair, because I know one of the challenges that we will face as a country, because private dental practice is perhaps lucrative, and we may have, I don't know whether we have a shortage. Are you in a position to indicate whether you might have challenges to fill those positions? Yes.
Well, I think it would be difficult to say, because what would have been happening in the past, those positions would have been filled or sought to be filled through the Public Service Commission. Having handed those positions across to the RHAs, they can then recruit using their recruitment process. So it's not quite the same. So I expect to get better results in terms of filling those vacancies once the RHAs are fully empowered to do so.
Thank you, PS. Madam Chair, if I may, just one more question. And again, this is related to the Ministry of Health Administration pillar. And I'm looking at the top of page 12. And I just want to read so that you can, PS, maybe you can comment on this. And it says, review assessment on the improvement of CDAP is being undertaken for more effectiveness and service delivery to patients. Now, we know that CDAP is a very important component of drugs to patients and citizens in the public health sector at subsidized costs. And well, in fact, it's free at the point of delivery. Can you indicate what this statement means? What is the intention?
Sure, through you, Chair. So it is exactly what it says, member. We are reviewing CDAP as part of our normal ongoing monitoring of our respective programs. There's a review currently underway, looking in terms of not just the diseases, the actual drugs, but also the even management of CDAP. And once that review is complete, based on the recommendations, we will then act on those recommendations.
Thank you, PS. Madam Chair, I have a few more questions, but I can give way if there's any other member who would.
Thank you so much. Thank you so much, Dr. Bodo. Can I call now on Member Dionarine?
Thank you. Thank you, Member Bodo. My question, I have several questions for PS Ali, Madam Chair. And I would like to first allude to the fact that in the Welsh report, they made reference to other areas of healthcare delivery, and they did draw reference to cardiac services. And they did mention that there's a massive demand and burden where cardiovascular disease is concerned. PS, are you in a position to tell us on an annual basis how much it is we usually spend on cardiac care in Trinidad and Tobago?
Through you, Chair, member, I will have to get that for you in writing, because that's a combination of expenditure we spend both within the public sector, and there is some level of outsourcing of services. So I can get you those figures in writing.
Okay,
well, that's with me right now.
Sure, I would appreciate that. But with respect to the outsourcing of services, what exactly in cardiac services you all outsource? Is it the bypass surgeries and so on?
Sure. So we outsource some angiograms, angioplasties, and yes, some of the bypass surgeries. Correct.
Okay, and also if you could submit to us in writing, are we on par in terms of payments for these outsourced services?
Sure, I can do that.
Okay. Now, also in your response, you would have alluded to the fact that you all are working on some clinical guidelines and protocols for chronic diseases. Could you tell us the cost of this and also the status of implementation?
Chair, through you, I will let CMO speak to where we are with regard to that particular initiative, please.
Okay, so in terms of the guidelines, we're looking at revising our clinical care guidelines for a number of diseases, starting with the non-communicable diseases. We're looking at hypertension, diabetes, and then a number of others that will follow thereafter. So in terms of our completion, we're looking at the HEARTS initiative, which is an initiative to actually change the way we dispense and change the clinical guidelines for hypertension treatment. The phase 1 of HEARTS has been implemented last year, I believe, the end of last year, meaning that we now have drugs that were different. So we would have had to change our formulary to go forward and take us into the new clinical case definitions and the clinical use of hypertensive drugs under that initiative. And they would be rolled out to the primary care setting in the first instance and then the secondary care. Similarly, for diabetes, as well as other non-communicable diseases, what we did is through the IADB loan, we are in the process of actually having technical advisory groups formulated with various specialists. And we did have a couple meetings internally in the country where we brought for example, we would have brought the endocrinologists together. We would have brought those medical internists at the hospitals together and got consensus. And this was run by a program developed and through the Pan American Health Organization. So they would have had workshops to actually develop the technical advice from our local specialists. Those would have gone abroad through a PAAC collaborative effort with the McMaster University to put it into a proper guideline form. But so we are far way on with regards to the cardiac reformulation, diabetes, and we have already started the hypertensive reformulation through the HEARTS initiative.
Oh, thank you, CMO. Do you have an idea when each one of them is expected to be completed, especially the HEARTS initiative?
Sure. The HEARTS initiative has been started already. There's 2 phases to the HEARTS initiative, meaning there's a recommended first phase where we use a certain type of drug, and then there's a second phase. So we can provide you with our implementation plan for the revision of the guidelines, if you wish. I suppose we can give that in writing as well. Yes.
Sure, we would appreciate that.
Sure.
Okay. Can I now go on to Member Mark? Member Mark? Okay, so while are you hearing?
Yeah, very clearly.
Yes.
Yes. Madam Chair, just a few questions to the distinguished acting permanent secretary, and that has to do with a follow-up on my earlier inquiry. And that has to do with this effort by the Ministry of Health to develop a longer contract arrangement between NIPDEC and itself for procurement, storage, and distribution of pharmaceuticals and non-pharmaceuticals. So I would like to ask the permanent secretary the following. When will the assessment of the contract arrangement between NIPDEC and his ministry for the procurement, storage, and distribution of pharmaceuticals and non-pharmaceutical be completed? That's the first question. The second question is, what is the current arrangement with regard to the procurement, storage, and distribution of pharmaceuticals and non-pharmaceuticals? And finally, who at the ministry is responsible for monitoring the arrangements for the procurement, storage, and distribution of pharmaceuticals and non-pharmaceuticals? These are my three questions, Madam Chair, and that is my final engagement.
Thank you. Through you, Chair. Let me take it from the top. With regard to the first question, we expect to complete that review during the course of this fiscal year, Senator Mark. I expect by second quarter of 2021, we should be complete with that review. With regard to the procurement of farm and non-farm supplies, that is currently still being done by NIBDEC on behalf of the ministry and the rest of the public health sector. With regard to your third question, in terms of within the ministry, the responsibility for monitoring that particular function, it is a multidisciplinary approach. We have within our drug inspectorate, within our finance and accounts department, and under the office of the CMO, it is monitored by those three departments based on the various aspects of it: financial, inventory management, and the actual pharmaceutical in terms of standards and the regulatory part of it.
Yeah, Madam Chair, I would like to crave your indulgence to just ask Mr. Sawyer-Fat whether he can share with this committee the extent of the operations of the Arima Hospital. In other words, is that hospital fully operational or not? Could he clarify and give us some upstate status report on the Arima General Hospital?
Chair, through you, I would be willing to answer if it's the San Grande Hospital, but the Arima Hospital belongs to Mr. Davlin Thomas at the North Central RHA.
Oh, sorry, sir. Sorry. Well, Mr. Davlin Thomas, please.
Through you, Chair, I'd be happy to say the Arima Hospital. I'd give a general sense, and then the Director of Health for the North Central Regional Health Authority will expatiate that currently we're decanting the Arima Hospital of the COVID-19 suspected cases to be able to operationalize that hospital within the next 2 weeks to ensure that to provide categories of services, namely initially some inpatient services for patients attached to the Department of Medicine, and then subsequently we're currently providing some with some minor surgical services, and so the first phase would be inpatient services. Then we'd extend that to some outpatient services, meaning that some of the clinics associated with those kinds of services, minor surgeries, same-day surgeries, which are critical, and then the emergency department will move across to provide the full service. I don't know if the DOH would like to expound.
Thank you. Through you, Madam Chair. Yes, according to, in addition to what the CEO said, after the initial 2 phases, we will now begin to expand to begin to introduce further services. Currently, we have support services already working in Arima Hospital. We have the radiology department, we have the lab in operation. So subsequent to the 2 phases the CEO talked about, we go into the 3rd phase where we introduce additional services, inclusive of now in-service surgical services, admission for services, and other additional services, including dialysis, and subsequent to expanding to include even other subspecialties in medicine, for example, in pulmonary medicine and nephrology and endocrinology. So that is the 3rd phase, the last phase of the expansion.
And when are we expected to complete the entire expansion to make it fully operational? Is it at the end of this year? 2021 or maybe in 2022. Is there any deadline for it?
Senator, if I may interject. So the Arima hospital was started, as they said, as a suspect hospital for COVID-19. I don't think any of us can tell what the trajectory of COVID-19 will be over the coming months. So what we're hoping to do is actually use Arima in the near future, probably from March or thereabouts, to go back to its original function in phases. Having said that, if we do see an increase in the number of cases in COVID-19 in Trinidad and Tobago at some point, then there may be a reversion of services back to COVID-19, whether for positive patients or possibly positive and suspected patients as the need may arise. So I don't think it is fair to ask North Central to put an end date to that. I think we will all have to wait and see a little bit, but I'm sure they can guarantee that in the month of March, we are looking to at least start services, and then we can take it phase to phase once COVID-19 remains a little bit under control.
Thank you. Thank you.
That's it, Member Mark?
Yes,
for now?
Thank you very much.
Okay. I just wanted to ask something. I'm not sure to whom to direct this. The installation and operationalization of the linear accelerator St. James Medical Complex, which is something that has been completed. What is the benefit of that to the public?
Through you, Madam Chair, I would want Dr. Smith maybe to just give us a little update on that, please. Thank you.
All right.
Yes, please.
Yes. Good afternoon, Madam Chair and the rest of the committee. The Linear Accelerator project is a major project that was initiated to really bring oncology care, and more specifically, external beam radiation therapy into the 21st century. Before, in the public sector, all we provided was, in fact, cobalt therapy, which is, of course, the old technology for treating radiation, but it comes with its own risk and limitations. By bringing linear accelerator technology into the private sector, which would allow for IMRT, VMAT, and all the high-tech issues, we have brought about a more accurate and safe method of treating our cancer patients that require external beam radiation. And it also complements well our other services there, including our brachytherapy services. So it brings our entire cancer care services in terms of treatment up to par and up to scratch with respect to international standards and protocol. We also will continue to use, of course, the cobalt machine, but that would be used more for palliative patients and what we're doing, the spinals and so forth, to ensure patients are pain-free. But now we have a complete cancer center that could provide total and comprehensive care.
Thank you, Dr. Smith. And maybe you could assist me in terms of this. I understand that, okay, we have some state-of-the-art technology. In terms of your recurrent expenditure, are you sufficiently funded to ensure that this system continues to function? Is there built-in preventative maintenance with adequate funding and so on?
Thank you for that question, Madam Chair. The good thing about it is it's a new machine. It was about an approximate $85 million project, correct me if I'm wrong, PS, between $80 and $85 million project. The policy of the Ministry of Health with respect to major medical technology within which the linear accelerator will fall requires that together with the one-year warranty that comes with the equipment, the ministry requires that we purchase an additional 4 years of warranty coverage. So right now that machine is under warranty for its first year of operations, and then we have purchased additional warranty coverage for service. So at this point in time, we are well covered at that point.
Okay, so I thank you for that, and congratulations for that. What happens though when it breaks down? So we have coverage, but in terms of, is there going to be a time lag? What kicks in? Because we know the incidence of cancer in this country. what kicks in? Do we go back to cobalt? Do we have alternative equipment, or would the contractor then loan us something? Is it readily available here? Those sorts of things I'd be happy if you could address.
So let me start with the first question. It's not advisable to switch therapy. So which means if you're on LINAC treatment, we wouldn't switch you to cobalt. So what we'll try to do is complete the treatment plan under the LINAC. Because we have only one linear accelerator in the public sector, it means therefore, if we need to switch a patient because of the machine being down and they are currently on treatment, and this is treatment 4 of 15, let's say, we have options in the private sector because the Ministry of Health also has relationships with both the private providers for linear accelerator technology. So we can switch the patient from one machine to another within the system, in the larger health system, both public and private. So that is not an issue. With respect to your specific question of what happens with respect to when the machine goes down, the maintenance contract we have is for specific downtime. So we have a 97% uptime with respect to ensuring the machine is up in those times. So I can say without fear of contradiction, the problems that we have had with the machine in recent time with respect to breakdown has not been with the machine itself, i.e. the linear accelerator, but with the UPS system in terms of making sure we have a clean power supply coming to the machine because it's very sensitive. So far, knock wood, we have not had the issue of any major downtime that would have affected or having to transfer patients from one system to another, one linear accelerator system to the other. But so the intent is through the preventative maintenance program to keep that machine up, and therefore patients can be planned accordingly.
And just let me just push the envelope a little further. How do we address that power supply issue? Is it a question of backup power, generators? How do we address that?
So the issue with respect to the UPS is just it was a function not because of our power supply. We did some upgrade work as well at the St. James Medical Complex prior to the installation of it. So the project had, because we were bringing in that new machine, the power source in terms of the large electrical framework had to be upgraded, so and the entire grid. So that has been done. The actual problems I was describing with respect to the UPS were mechanical problems related to the UPS and not the source of power. So the UPS itself had a problem as opposed to the power coming to the UPS. So at this point in time, we are good. So the power supply so far has been good and has been regular and has been secure.
Okay, thank you very much. And Dr. Bodo, just before I call you, I just want to switch back to, and maybe this goes to the North Central. I wanted to find out a bit about the Arima Rehabilitation Center. I don't know under whose remit that falls. And particularly, I think it's at page 9 of the submission, where they say it's a key activity, but it has not yet been restarted. And hopefully this fiscal, dependent on funding availability. So what I'd like to find out is if we could get a little detail about the progress, whether the budgetary allocation for has included what is required to be done to restart and complete this project. I know the releases is one question, but I want to know if the allocation that the ministry has received can satisfy the startup and completion of this rehabilitation center.
Madam Chair, we are at the stage where we've appointed a small committee to engage the needs associated with the rehabilitation center, and it's really at its embryonic stage. So we anticipate that by the end of February, we should be able to articulate with some clarity to the Ministry of Health exactly what it would take to ensure that we have those that we could activate. And that's currently the position.
you're talking about budgetary and everything like that.
Yes, Madam Chair.
All right, so you said the end of February.
Yes.
Okay, thank
Madam
you.
Chair, Madam Chair, sorry, if I may just add a bit to that, please.
Yes, Mr. Ali.
So the Arima Rehab Center, that facility, is part of our overall mental health program. So we are currently engaged in finalizing our decentralization plan for mental health services. So that will also inform part of what Mr. Thomas is speaking about. So that's just one part of the puzzle in terms of that overall plan for decentralizing mental health. Thank you.
Okay, so as you said that, Mr. Ali, you just reminded me. In the report, they were talking about that the users there were just some very old senior, let me put it that way, senior persons who couldn't take the benefit of what the center was initially established for. So have we at all migrated other people into it, or all of that is pending the resuscitation of the center and, of course, the decentralization of mental health facilities?
Sure. So I will let the RHAs answer whether they've taken in additional clients, because that's directly under their purview in terms of management of the center. Thank you.
Hi, good afternoon, Madam Chair. Through you, of course, the St. Anne's Hospital would have transferred at least 28 patients to the Arima Rehab right now. They were long-stay patients, so that was part of their decentralizing and reducing the patient population at St. Anne's. But yes, it's not, the patients will not be what was initially envisioned for the purpose of the Arima Rehab Center, but they are mental health patients there.
And the 28 who were transferred by the St. Anne's Hospital, is that now the total complement of its population, or does it service a greater number?
Those 28 in addition to an additional 10 that were transferred from Port of Spain General Hospital. So in total, there are 38 patients there.
Thank you very much. And might I just ask one question? How does the non-completion of or the state of the facility affect the service delivery in this aspect?
Thank you, Madam Chair. As the PS would have mentioned, in terms of the overall national plan for mental health, the refurbishment of the Arima Rehab is part of that, as well as realigning the services of Arima Rehab as part of the national movement towards decentralization of mental health.
All right. So as we were told, we should expect that you all will complete your report by the end of this month. So then could I ask that maybe by the middle of March, if your findings could be shared with us and a sense of direction be shared with us, please?
Yes.
Thank you.
Madam Chair.
Member Bodo.
Thank you, Madam Chair. And this would most likely be my last engagement with the stakeholders. I just want to direct this to PS. I'm looking at the update of the annual services agreement between the Ministry of Health and the RHAs. I know that we still have the purchaser provider model, PS, where the RHAs, where you have an agreement, but I know that hasn't worked for a while. Can you give us an update as to how it's working, whether it's been strengthened, and whether you're achieving what these agreements are meant to do?
Sure. Through you, Chair, Member Bodo, maybe I can let Mr. Jai Singh, who is our point person dealing with the ASAs, give an update on that matter, please. Thank you.
Sure.
Thanks, Member, for the question. Yes, indeed, the annual service agreement was repurposed in 2019-2020 in alignment with also our strategic framework itself. Right now, we are updating the ASAs as we speak, because we have updated, because of a new 5-year fiscal year, we are currently pursuing and updating our strategic plan. And based on that, there will be a new purchase intention agreement, which will, and the ASA now will fit into that in terms of the new priority areas. But as it is right now, we are tailored the ASA to a smaller set of indicators that can be quickly and easily reported on. So we have RHAs reported on the ESAs, right now based on the priority areas, but as the case might be, there will be a further revision based on our strategic plan that is almost completed. And we're hoping by the third, fourth quarter of the fiscal year, our ASs will be ready for signature again. But right now, we are developing the process flow arrangements to make sure that the indicators are aligned as much as possible to the strategic framework for reporting.
Thank you, Mr. Dysing. PS, if I may direct your attention to the item Roman numerals 8.7, the manpower plan is being reviewed and strengthened to identify the possible shortages of staff required for health professionals, including the doctors, nurses, and allied health professionals. Can you give us an update on the status of that manpower review?
Sure. Through you, Chair. Thank you. That review is currently underway. We hope to have that completed during the course of this quarter. Of course, because of COVID and the HR requirements there, that has added another layer, another factor into the mix. All right. So we are currently almost complete with that, and that would also cater for the new Brandy Hospital as well as the new central block, because we want to cater not just for today, but we're looking forward also. It is our future planning.
Thank you, PS. I just want to close off with one last question. And, I just want to take us back to why we are having this inquiry. And it really is to look at the efficiency of the RHAs. And in view of the fact that, over close to $6 billion are expended annually from the public purse, and about over $4 billion spent by the RHAs, as to whether the efficiency, and in fact, the Welch report asks the very question as to whether the RHA model is the best model for delivery of health services to the population. So I just want to ask you, now this is one of the something that is outstanding, and it says review and assessment of the RHA structure. It's at the bottom of page 13. It says review and assessment of the RHA structure and arrangement to determine whether it is effective or should be replaced to ensure efficiency of operations in the provision of health care. PS, is it the intention to actually undertake this review? And if so, how soon?
Through you, Chair, yes, we would want to undertake that review. If I were to be quite honest, I can't give you a time to remember. We would like to do it during the course of this fiscal, but at this point, I don't have a definitive date when we want to start that actual review.
Thank you very much, PS, and thank you all for your contributions. Thank you, Madam Chair.
Thank you very much. And I'm reminded of the time, but I just wanted to maybe just engage us a little longer. And PS, if I could refer you to page 12 of the submission, and it's just really to do a tick-off list in terms of, we were told that the filling of the positions at the nutrition and metabolism division has been advertised. Can you say what the status is of this?
Sure, Chair. So we have actually recruited through the Service Commission Department our chief nutritionist, that's the head of the division. That person has been engaged, and we have also been able to recruit some of the lower level positions. There are still some vacancies, but that recruitment is ongoing. But the head has been recruited.
And could you say, if at all, the filling of the positions that you've done, and also if that has helped in establishing any sort of efficiencies in this service?
Definitely. So what it has done, I spoke a bit earlier in the session about, I referred to an IDB loan. That loan is to help the ministry with its NCD dry, non-communicable diseases. A key part of that is nutrition. So having that director on board has brought that technical expertise to be able to provide that technical advice as we plan our NCD interventions from a nutrition perspective. So to answer your question, yes, it has definitely assisted us.
Okay, and in terms of this, I see that you all were doing a review and an update of the handbook of policies for the Ministry of Health and the regional health authorities. Could you share with us where this has reached?
Sure. So there are many different policies within the Ministry of Health. We have our clinical, technical policies, and we have our HR policies. With regard to the HR policies, we currently are engaging a consultant to review the work that has already been done to finalize those revised HR policies. That should not be a very long consultancy. I expect within a month or 2 months, we should be able to complete that exercise. So ideally, during the course of this fiscal year, we will have completed a review of our HR policies. I would let Mr. Jai Singh just speak to the other policies, please, in terms of where we are with those.
Hi, Madam Chair. Yes, indeed, we have done a template to collect all the policies from the various RHAs. This has been completed since 2018 and has further been updated. Last year it was updated as well to make sure that policies similar policies are compared with RHAs as well, but also that if one policy is done by one RHA, it could be shared easily and quickly with other RHAs. That is the intention of the handbook. So person could see exactly what are some gaps, what are some challenges in policy development, and also what are some policies from a national perspective that we are actually undertaking in our ministry itself. So it's been shared across RHAs and it's currently being updated every quarter.
Yeah. So might I ask, do you all do systems audits? And if you all do, how often or when last the systems audits would have been done of the, I mean, not just talking about, financial audits, system audits in respect of the RHAs and in respect of the Ministry of Health?
Sure, thank you, Chair. So with regard to systems audits, yes, we do. That is part and parcel of the work plan of our audit department. We would appreciate that based on staffing constraints and the other workload that they have, we may not do as many systems audits as we would like within the ministry. With regard to the RHAs, that falls under our quality department. We have had some vacancies in our quality department, so we are currently trying to beef up our quality department once again to really restart doing those system audits in a meaningful way at the level of the RHAs.
Okay, so what I'd ask Mr. PS, if you could share it with us in writing, the last time systems audits were done in each of the entities and the key findings of those system audits and any sort of remedial steps which were taken. I'll ask you to do that in writing.
Sure.
Okay. And I'm just going to detain us with 2 more questions. I mean, we have many more, but we will, forward them in writing for you all to answer. Now, I think the CMO spoke at length about the transfer of the dental services to the RHAs, but that's just only one of the vertical services. And in terms of key activities not yet started, the other vertical services are to be transferred at some time. And what we're told is that there's an analysis being done to determine feasibility and streamlining of service delivery. Could you give us some idea of where you all have reached with this and when you are likely to complete your analysis to know how you're moving forward with the other vertical services?
Sure, thank you, Chair. We're in February. I expect by the 3rd quarter of this fiscal, we will be completed with that analysis, and then we'll be able to, at that point, determine which verticals we do next and in terms of the sequencing, because some of them may not be as complex or as detailed as dental, and we may be able to do some of them concurrently. So that's actually what we're trying to work out right now, the sequencing and the timing of that decentralization.
Okay, and the elephant in the room, the second report, which is to rationalize the system of public sector doctors in private practice. Give us an idea, because what we've been told is that you haven't started on this. So could you give us an idea of when these consultations are going to be taken to be held with the Medical Board of Trinidad and Tobago to design a possible way forward? How long you think this is going to take before you are able to ascertain whether it's feasible?
Sure. So what we've done to date, if we recall the report number 2, as we said, there would have been 2 options put forward by the committee. One would have been the outright cessation of private practice. The other would have been continuing with some level of private practice, but putting in place performance indicators in terms of managing the output of those physicians. What we've done at this point would be to focus on that latter option. So at the level of the RHAs, and the CEOs can speak a bit more, and the DOHs can speak a bit more to it after I'm finished, we've actually started to look at the performance management system with regard to really managing the contracts we have with those physicians at this point. I'm not sure which RHA wants to really step in first to speak about what they've been doing and their experience so far in that regard.
Okay, so could we start with the North Central?
Through you, Madam Chair, the North Central Regional Health Authority is really focused on the outcomes and the outputs associated with the services that are provided by those practitioners. So, for example, we were able to record increases in the numbers of surgeries, particularly, which is being monitored not just at the executive level, but by the subcommittees of the board and the board itself. So just as an example, we would have engaged the practitioners via the DOH and so on, and the medical chiefs of staff to ensure that we increase the number of surgeries that were provided in 2018, 2017, to the extent where we would have identified an increase in 2,000 additional surgeries. So, and that's what I mean from the approach of outcomes. The number of patients, for example, that we were able to provide ophthalmology services, the number of orthopedic surgeries would have increased exponentially. So one of the metrics that we would use to provide us with the monitoring that would be meaningful to the population would be identifying what these outcomes and outputs are that we anticipate, and certainly to ensure that we work toward those outcomes and to exceed the expectations and certainly the outcomes that we had projected in the past.
Okay, thank you. Could we then go to Eastern?
Thank you very much, Chair. I just want to say that we have, in the short term, we have been addressing this through engaging with the heads of departments, the consultants and so on, to ensure that the throughput is increased in terms of, all our services and so on. We have, through this engagement, been able to reduce reporting times, reduce surgical, waiting times and that type of thing. In the long term, what we need to look at, and we are looking at, is the performance management system that will kick in terms of the long term, being able to monitor the performance of your consultants and link, of course, as my colleague says, to the outputs that they're in. But we have been engaging directly particularly through the hospital medical director, engaging directly with the heads of department, and we have been seeing remarkable improvements in terms of waiting times and, reporting times and so on.
And doctors' presence.
Also.
Can we now have the Northwest?
Good afternoon, Madam Chair again. In addition to the measures that my colleagues would have spoken to, we also have internally started to review of our performance measurement tools. We have rolled out two tools at both St. Anne's Hospital as well as St. James and we are working on revising our tool for Port of Spain Hospital. And in addition to which, our medical directors are increasing their case reviews, which is a peer-based related initiative where these doctors are entitled to attend and review their performance, their clinical performance. So with that increase of case reviews, that's more supervision, and in terms of assessing their clinical performance and seeing where the gaps are and rooms for improvement. So that's what we have been doing as well.
And you've been seeing some improvement just by that sort of monitoring mechanism?
Yes.
Okay, and might I then, thank you very much, invite the Southwest Regional Health Authority.
Thank you, Madam Chair. It's similar to my colleagues in the other RHAs. Yes, we look at performance outcomes measures in terms of, there are three, in terms of the medical administration, you have your registrars as the first tier of the senior doctors, then specialists, SMOs, heads of departments, medical director, director of health. So it's a pretty, relatively tall structure. So underneath those, you have medical, surgical, and their subspecialties, and obstetrics. Those are the three big arms for which you have specialist medical officers. So the performance metrics has to be tailored to meet those big sub areas. In total, we have 17 heads of departments across those three broad areas. So you would find generally in the surgical services, yes, our outcome measures are the number of surgeries being done that can be disaggregated with our increasing automation of performance down to the individual specialist medical officer, as well as through the quality departments. We look at customer feedback in terms of outpatient clinics, time to start, complaints, and we even do like time motion studies where indicated. And of course, we have quality, as I spoke of the systems audits, we look at infection prevention and control practices. So those are the outcome measures that we measure. And as we like to say in this field, nothing documented, nothing done. So therefore, we look at quality of documentation. So all of that has a secondary gain as a senior doctor have to be present. Medical specialties, we find that the performance metrics there relate to a lot of support services for end organ damage, whether it be dialysis, whether it be non-surgical neurological interventions, and gastrointestinal and so forth. So the similar metrics, not so much surgeries, but more so in terms of the care and the specialists, minimally invasive services. So that is what we would see. So some of these medical services, they could do minimally invasive procedures where they take tubes and look down your throat, or look down your airways. So that's the sort of performance metrics we have there. And then the obstetrics and gynecology is well supported in the country with the Ministry of Health direction that has been stated publicly, led by the Directorate of Women's Health. And because of the nature of that field, the performance metrics are different yet still. So what you find is that the doctors there, they have improved accountability in terms of registrars must be on site, in terms of doing much more peer reviews, grand round reviews, as the CEO of Northwest said. So what we find in terms of performance management at the specialist level, it becomes quickly customized. And with the policies of the Ministry of Health, with the vertical units, with looking back at our customer feedback, our adverse events, you find that we are very attuned to the needs of the doctors. Actually, you'll find that the senior doctors' compensation it's like everybody else for your basic needs, but senior doctors need to find themselves in an environment where we say see one, do one, teach one. So we also have to build a culture of mentoring, supervising, and for that there's also a strong component with the University of the West Indies. So we also some emerging metrics in terms of how you train, supervise, mentor, run your postgraduate programs for the junior doctors. All of that comes into play in performance management and what we do.
Thank you very much. I think we will continue that conversation with some further questions. And in terms of filling positions, Mr. Pierce, might I ask, I noticed that in 3 of the regional health authorities, we have a CEO. In one, we have an acting CEO. What is the position about filling that post?
Thank you, Madam Chair. We are currently in the process of advertising that position and would have been filling that position.
The advertisements been placed or not? Or they are to be placed?
To be placed.
And could you give me an idea of how soon that will be done?
I will have to get back to you because that falls under the purview of the board of directors. So I will have to follow up on that for you, please.
Okay, so if you could give us that in writing. And the last question to you, Mr. Pierce. Are you satisfied with the rate of implementation of the recommendations?
Bearing all the factors that are impacting upon the implementation rate in terms of, we mentioned some of the, well, I don't say challenges, the factors, finance, HR, systems, the support systems, the pandemic and everything else. I am reasonably satisfied. I will not say I am satisfied, but I am reasonably satisfied, if not wholly with the rate, but at least with the effort and the commitment of all concerned at the level of the ministry and also particularly at the level of the RHAs, starting at the top and going all the way through.
Okay, and therefore what I'd ask you to submit us in writing, how do you think this committee could help you with the areas that you feel, those challenges that you feel that are affecting all the good effort and goodwill of all the players in trying to deliver better health to the public of Trinidad and Tobago?
Not a problem. I am sure my colleagues around the table will be only too happy to sit with me and send that to you as soon as we can. Thank you very much.
Thank you very much. Okay, so that therefore I want to bring this part of the inquiry to an end. It's almost 6 o'clock. I know you are all very busy, but I want to thank you for the very fruitful conversation. I want to thank you for the patience with the technology and, for giving so willingly to the committee and by extension to the public of Trinidad and Tobago. I join with the members of my committee in congratulating you all with all the gains that we've benefited from in these very trying times. We all watch international television and sees what happens in countries that are first world. And we still owe a great debt of gratitude to the public health players, the players in the health service, both administrative and professional medical nursing. So I want to say thank you. I want to wish you all a good evening and a safe journey home. I want to thank the members of the listening public and the members of the media who've stayed with us. Thank you very much. Pleasant evening. Goodbye.
Thank you.
Thank you, Madam Chair.
Thank you, Madam Chair.